Welcome everybody to the third lecture in our Learning Health System series. Thank you everybody for attending. I know it's spring break for some of you on the academic side on campus, so I'm really happy to see all of you here today. So for today's lecture, I'm very pleased to introduce Jeremiah Brown. Dr. Brown is a professor at the Dartmouth School of Medicine. A lot of his work focuses on predictive analytics using data, I guess, to drive improvement. I think sort of in a broad way, that's what he focuses on. A lot of his work specifically is focused on issues with respect to cardiovascular disease. And as I'll talk to you today, he does a lot of work on acute kidney injury. And in fact, he does a lot of work with the Acute Kidney Injury Network, helping to develop guidelines and such within that network. He's very prolific, over 150 publications, and he does very well also in getting grant funding and he's been funded by ARC and NIH and the VA. And so Dr. Brown, Jeremiah, it's all yours, and thanks again for doing this for us today.
Great. Thank you, Allison, and thank you everyone for joining on your spring vacation time and it's a privilege and honor to speak to you today. So these are my funding disclosures, 4 R1s, 3 that I'm a multiple PI on, and I'll be talking to you mostly about this Improve AKI randomized controlled trial that's a hybrid type 1 effectiveness implementation trial. So the overview for our session, I'm going to introduce this concept of acute kidney injury, so you will all master that by the end of the talk. And then I'm going to go into some of our early work in this area where we identified variation and produce an action plan in terms of how to address this issue of what we call AKI. I will go through very briefly a regional learning collaborative that we developed as a large-scale pilot to inform this national implementation trial called Improve AKI, which the automated surveillance reporting dashboard that we'll be speaking about today is one aspect of that intervention, combined with 2 other interventions that I'll go over later on in the talk. And then hopefully we'll have some open discussion. So let's start with, what is this issue of acute kidney injury, and specifically what we call contrast-induced or contrast-associated acute kidney injury. So clinically, we define this as an acute rise in serum creatinine within 48 hours, and defined by a 0.3 milligram per deciliter increase from baseline, usually the most recent creatinine, serum creatinine from baseline, to the highest level within 48 hours. It could also include just a 50% increase from baseline, but usually the 0.3 milligram per deciliter increase captures most patients. Or it could also include a new onset of dialysis with no history of prior dialysis for the patient. So what occurs, especially in the cath lab, specifically we're talking about coronary angiography or percutaneous coronary intervention or stenting procedures. So both the diagnostic as well as interventional procedures. During or shortly after the exposure to contrast dye, or even could be induced from some baseline comorbidities like diabetes or nephrotoxic drugs that could cause this, but most likely in the cath lab, it's being caused from the contrast agent. This can result in a rapid decline of renal function, and then in most patients will recover and patients will do fine. In some patients, that recovery will only be partial, and they'll progress to chronic kidney disease or a worsening state of chronic kidney disease. Or they might progress more severely to an acute on chronic kidney disease state, or progress directly to going on dialysis or end-stage renal disease. So this is a schematic we actually developed in the first textbook chapter in a cardiovascular interventions textbook on acute kidney injury. And here we depict actually access through the femoral artery. Now it's being done through the arm, through the radial artery. But the contrast here is depicted sort of in the green shadows or green death. And so if you look at the bottom of the picture, you have a picture on the left of a normal tubular lumen. And when it engages exposure to contrast, that causes acute ischemic injury and chemotoxicity. And that results in acute tubular necrosis and eventually cell death. Also, what's happening is the production of free radicals, and that can result in the cells being attacked by the free radicals and undergoing oxidative stress. So that just gives you an idea of what's happening with the contrast. This is a CT-gram of looking at contrast. You can see in the kidney medullas there that look like, beans there. On the outer portions, you see the white areas. So that is the safest contrast dose, safest contrast agent out on the market. It's an isoosmolar contrast agent called Visipake. You can see at the time of bolus in the top left corner, 3 days later, it's still there in the medulla areas of the kidney. 8 days later, you can still see about a quarter of the contrast die. So going back to our schematic, that injury is going on not just in the short and brief exposure during contrast, but it could be going on for a matter of days, if not weeks, causing continued renal dysfunction and oxidative cell related death. And this is important because a lot of research has been done to sort of look at acute kidney injury and other end organ injury. And what some of the molecular studies have done is identified that AKI, or the signal coming from the kidney, is really the first domino to fall in a bad series of events. And confirmed by sort of molecular biomarker tracking of end organ injury, this has been documented following AKI. You also have increases in other end organ injury biomarkers that are resulting end organ injury from the kidneys being harmed. And looking at multiple randomized clinical trials, the question is, does acute kidney injury result in death? Yes, it does. And we looked at our own cath lab data when we first started looking at this. In white, on the white line there, you see patients that don't develop acute kidney injury. In green and red, respectively, we see patients in green that had a persistent decline in renal function. So those are patients that did not recover within 2 weeks after the procedure. Their renal function did not recover, or a transient increase, which is in red. And what we found that whether you have a transient or persistent decline in renal function, so whether you recover or not within 2 weeks, you still could have a 50% mortality at 2 years. We looked at this in another way in a VA study, where I did some work with the VA CART system and also Mark Saranac at Tufts. And we looked at, does AKI progress to worsening stages of chronic kidney disease? So in the top left corner, we have the red line, which are those patients that went to the cath lab and had acute kidney injury. On the blue line is the cath lab patients that didn't develop acute kidney injury. And the green, we have population matched controls within the VA. So matched for other chronic comorbidities to the best possibility that we could. And what we found was that patients developing AKI were 2.5 times more likely to progress to a worsening stage of chronic kidney disease. They have a higher incidence of undergoing dialysis, and they had a twofold more likely occurrence of having a subsequent myocardial infarction or die. So it's pretty serious stuff. So we then started to look at meta-analyses and approaches of how can we prevent acute kidney injury from happening. So this is a meta-analysis that was done looking at different contrast dyes, specifically isoosmolar contrast, which is considered the safest contrast type on the market, versus low osmolar. The high osmolar contrast agents are not used for cardiac procedures. And this shows that the isoosmolar contrast agents were actually significantly reduced the risk of acute kidney injury. And then we did some work looking at safe dosing of contrast. And here we use the maximum acceptable contrast dose equation, which is just 5 milliliters times the body weight in kilograms of the patient divided by their baseline serum creatinine. And that calculates a safe threshold of contrast to use for the procedure. And what we found is that if you go over that safe contrast limit, so here we just have a ratio. So if you go above 1, if you go up to 50%, you have a 13% rate of AKI compared to 8 or lower. If you go up to 50 to 100% above the threshold, you're at an AKI rate around 20%, and even worsening when you go above a doubling of that threshold. So that we have used, I'll speak to later, as a threshold to have interventionalists try to avoid to prevent acute kidney injury. We also looked at other areas where we could target for improvement. And one area was looking at combination prophylaxis. And this was looking at IV fluids, whether normal saline or sodium bicarbonate, with or without the combination of N-acetylcysteine. And at the time, there were multiple randomized trials, and we found that the combination of sodium bicarbonate with N-acetylcysteine can lower the risk of acute kidney injury from randomized trials. And contrast-associated acute kidney injury is a very important area. It can cost the US health system up to $1.2 billion annually based on the 1.2 million angiography procedures occurring each year, and having each in-hospital occurrence costing the health system around $10,000 or $12,000 for treating a patient for a year. So where is the gap? So there are numerous clinical trials looking at different prophylactic approaches, multiple meta-analyses for contrast types or IV fluids, and multiple observational reports. But there's really no implementation science and no quality improvement activities that were ongoing for any period of time. So that led us to use our Northern New England Collaborative to really understand what was going on in terms of the variability in AKI rates, and could this inform how we could take action in our health system, and specifically in the Vermont, New Hampshire, and Maine 3-state collaborative. So this is the Northern New England Collaborative that consists of 10 medical centers in Vermont, New Hampshire, and Maine. It captures 99% of the percutaneous coronary interventions or stenting procedures in the 3-state area, and has been around for over 35 years. And what we found, using risk adjustment, across these 10 sites, we have 5-fold variability of AKI rates across the sites. And specifically, we wanted to understand what was occurring at the 2 top performing sort of what we call the benchmark sites that had their AKI rates significantly below the regional average, whereas we had high variability across the rest of the region. So we conducted some mixed methods studies to understand both the quantitative findings of AKI as well as the qualitative findings, and better understand what was driving the better performance in these top performing centers. And so we aggregated our findings in a couple tables. And the actual rates and the centers that are blind are on the top. And what we learned about these top performing benchmark sites was they were the only 2 sites that had changed their NPO orders, or nothing by mouth orders, to less than 4 hours or between 2 to 4 hours. And this was consistent with new anesthesia guidelines that came out in 2000 or 2004, and this is about 10 years later, saying that patients going to the cath lab no longer need to be NPO after 10 p.m. or after midnight, because the risk of going to an emergent CABG or coronary bypass graft procedure from the cath lab is extremely rare. So they changed their guidelines to 2 to 4 hours, but only the top performing sites in this case were actually following that, meaning that all the other patients at all the other sites were NPO for overnight and during the day while they're waiting for their cath lab procedure, so getting, and usually not getting IV fluids either, and not eating or drinking before they're coming in for their appointment. So they're coming in dried out and dehydrated, which is not good for prevention. We also found that were mandating IV protocols to push either IV normal saline or IV sodium bicarbonate. And what was unique about the top performing sites is that they mandated these order sets for all patients, and you had to opt out a patient if they're high risk, like for instance, if they had congestive heart failure. And they put them on a different IV protocol, like half normal saline. And all the other sites basically had write-in orders with no standardization of how they're managing IV fluids before or even after the procedure. And at the time, they were also using high-dose N-acetylcysteine, and this was before the ACT trial came out of Brazil that basically said there was no significant finding amongst like 4,000 randomized patients regarding N-acetylcysteine. But at the time, the best evidence was to use it. And excuse me, interesting, they're also using this iopamidol contrast agent, which was a low osmolar, not an isoosmolar, considered the safest contrast agent, but was actually used in a head-to-head trial by Rick Solomon and others at University of Vermont, showing that this low osmolar agent was no worse and might be actually better than the isoosmolar Visipate contrast agent. And in addition, it's much less expensive. And they were sort of using the evidence base of what the best performance sort of contrast or best cost-effective contrast agent out there on the market. And they're also using mandated post-procedural fluid protocols. And another interesting thing that we found was that these two sites actually had clinical champions, whether nephrologists or cath lab directors, that had implemented AKI prevention protocols at the sites, and all the other sites really had no one leading a charge or effort to try to address acute kidney injury. So that led us to establish some sort of best practices from these benchmark practice approach. And that was to avoid MPO after midnight orders and using the 2 to 4 hours pre that was consistent with the anesthesia updated guidelines. Establish pre and post procedure protocols for IV hydration or volume expansion, and using high dose N-acetylcysteine or Mucomyst at the time, and also recommend using this IsoView contrast agent, which is iopamidol. This led to a patient safety and acute kidney injury grant that was funded by AHRQ, and we later published in CIRC Outcomes. And so in this study, we had over 21,000 consecutive PCI procedures. So these are stenting procedures for coronary arteries amongst our 10 hospitals in Vermont, Hampshire, and Maine. And we had a baseline period of around 7,000 consecutive procedures and an intervention period that occurred for about 3.5 years of 14,000 consecutive procedures. And what we found is the benchmark hospitals, the A and B sites, are in red at the below. So they essentially didn't change their practice at a whole low adjusted rate of AKI over time. And after the red line is our quality improvement intervention, which incorporated learning collaboratives for these intervention hospitals. And what we found is after initiating this intervention, the risk-adjusted AKI rate in the intervention hospitals significantly lowered their rate of AKI over time, and specifically occurring just before and at the launch of our intervention. This was also found in our chronic kidney disease population, or patients that are presenting with pre-existing chronic kidney disease or glomerular filtration rates below 60. And what we found in all patients, we saw a statistically significant 15% reduction in AKI rates. And in the CKD population, we had a 28% reduction in AKI rates amongst our intervention hospitals with no change in our benchmark practices. And these findings were upheld using hierarchical Poisson regression, adjusting for patient factors and accounting for within and between center variability, where for all patients, we had a statistically significant 21% reduction, and for the CKD patients, a 28% reduction. So this is a mixed method study, so we also implemented sort of rigorous qualitative methods to understand better what was happening in terms of protocols or protocol shifts amongst the hospitals. And we took these findings in semi-structured interviews and aggregated the themes into key domains, which we came up with: teams, improvement barriers, improvement targets, improvement technology. And these are some interesting quotes, and I have to warn you, some of them are a little bit hilarious, but so beware. And so these are some interesting quotes that came from these frontline clinical care teams. The first one is around not having a protocol. So there's no specific protocol a doctor has to utilize in terms of the amount of hydration. So they're just, write-in orders. People had IVs, but it was at sort of KVO or keep vein open status, and they weren't bolusing fluids. They had to unlearn old routines. So everybody has their own little routine, and that was one thing they had to unlearn. And in terms of dehydration, they noticed that, with these ancient NPO orders, patients are coming in dried out. We have an opportunity to hydrate patients, but they're really just coming in dried out. We need to do something about that. An interesting quote from one of our centers, a nephrologist that was participating in the team said, "I like them juicy." There's no doubt about that. The juicier they are, the safer their kidneys are. But again, cardiology would have another opinion. You try to prune them, I try to plump them. So that was addressing some sort of differences in opinion in terms of how to manage patients. That was a little bit comical. And then in terms of how to manage contrast, a little bit more attention to detail allows you to cut your contrast volumes. And interventionalists actually spoke to like their approach differed across during the intervention and learning from their interventionalist peers how to minimize the use of contrast. And this speaks to that again, that they learned from the top performing interventionalists and top performing sites, how they could advance in the procedure without using as much contrast, for every time they had advanced the catheter or did some imaging. And this spoke to sort of some cultural changes where they heard, another interventionalist that wasn't actively participating in the study, but actually stopped the case because they're approaching their safe contrast dosing and actually stopped the procedure and brought the patient back a couple of days later to protect their kidneys. And finally, by the end of the study, there was a clear change in culture that the team spoke about. And that resulted in hospitals adopting benchmark hospital protocols. They had standard IV orders to eliminate the keep vein open status. They reduced the NPO status to 2 to 4 hours, consistent with the new guidelines. They stopped nephrotoxic drugs prior to the procedure. They worked on readiness checklists, including volume status of the patients. This is IV fluid volume status, and also fluid bolus status at their JACO timeout at the beginning of the cath lab. They also adopted new protocols for delaying procedures to allow for that IV fluid bolus to occur, so the patients had the adequate fluid bolus and volume expansion before the procedure. They also worked on areas to limit contrast volume and even conducted, and this is where they really innovated, one of the top performing sites trained the other sites to develop patient educational materials to say, look, we might not get it right all the time. So if we don't get your protocol or your fluid bolus going, what you can do at home is to self-hydrate with clear fluids. And we recommend having 8 ounces glasses of water 12 hours before and 12 hours after. So putting some ownership on the patient that should the system fail you, you can self-hydrate to try to protect your kidneys. And I thought that was very innovative. So that regional quality improvement study actually informed an implementation hybrid type 1 effectiveness implementation trial that we call Improve AKI that was funded by the NIDDK. And we reported our phase 1 trial results, and I'll tell you exactly what that is in a minute, at the ASN in November. So this is a multiple PI award. Myself, Michael Matheny from Vanderbilt, and Rick Solomon, who's a nephrologist from the University of Vermont. And some dynamics team members, including one of your own, Lisa Zupkoff, who was formerly at the VA up here and helped lead our quality improvement training sessions for our learning collaborative. So the study design for Improve AKI is a 2x2 factorial clustered randomized trial. And we randomized 20 VA medical centers nationwide to receive 4 different types of clusters that I'll speak to in a moment. And basically all VA medical centers, there are 76 of them, with cardiac catheterization laboratories were eligible. And they're all included for eligibility. And actually the National Center, or CART, put out a request to participate amongst the cath labs. And about half the cath labs responded, 20 ultimately ended up participating and being randomized. So sites were block randomized by VA region and patient volume for their cath labs. And patients age 18 years or older, this is in the VA, of course, they're undergoing diagnostic coronary angiography procedures or PCIs or having stent. Exclusion criteria is if a patient had pre-existing dialysis. So this is the schematic of the trial, so the 2x2 factorial design. So sites were either randomized to technical assistance, I'll talk to you about what that is in a moment, or a virtual learning collaborative where they're learning and being trained and coached together. But then we also randomized whether they're having this automated surveillance reporting dashboard that was being developed on the back end and provided to the sites, and I'll go through those methods in a moment, or they didn't have that turned on. So they either had the dashboard or they didn't. They had technical assistance or they had the learning collaborative. And I'm presenting to you this AIM-1 phase 1 results, and now we're in our sustainability phase. So again, we have these 3 core interventions that go into this 2x2 factorial design. One is this ASR intervention where the patients received access to the surveillance tools that provided measures, sort of the site's national risk adjusted ranking that reports the overall performance of AKI at each site relative to the national expectation. They also received site-specific performance summaries, which highlights whether the site is out of expectation with regard to their statistical process-based methods. So this is using risk-adjusted sequential probability ratio testing. And they also received a patient list in the dashboard, which showed them process and outcome measures, and I'll show you an example of this, but also could link them directly to their cath lab patient data to look up more additional information about that specific patient. So it makes root cause analysis much more easy in just doing sort of clicking on a patient and finding out more information within their own information systems. And then we also have the virtual learning collaborative, which I'll go over in much more detail, and the technical assistance. So I'm going to start with the automated surveillance reporting. So this is developed through a corporate data warehouse through the VA and the electronic health record data. It also includes registry data from CART, which is basically the national repository for cath lab data, and they produce reports and go on to submit that to the national NCDR for national reporting. The dashboard was provided monthly updates for analysis from the CART site, as well as for the sites to review. It included robust patient risk adjustment that I'll speak to in a little bit more detail. And the dashboard overall provides risk-adjusted site level performance compared to all other sites in their region, VISN, and national benchmarks, and provides risk-adjusted site level statistical process control analysis, and also the ability to access their site's patient identifiable case level data to support quality improvement and root cause analysis. So the risk adjustment modeling was based on a national models that we developed as a team prior to the award that was funded by HSR&D. And this included over 115,000 catheterization procedures, and then externally validated by the 10 sites in Northern New England and over about 28,000 procedures. And we looked at any AKI stage, but also different staging of AKI, and as well as patients went on to dialysis. So what the dashboard team also did during this time was recognize that the risk adjustment is only as good as the model supporting the adjustment, and the performance of risk models degrades over time. So what they did, and this was led by Sharon Davis, who's an investigator at Vanderbilt, and the VA there, to look at model drift over time and to accommodate and reevaluate or rescore the model if there is an observation of drift occurring. I think there's a paper out that's under review right now on that. This is the site-specific login for automated surveillance reporting. So team members were given access and specific logins so we could track them to access their dashboard basically through a web interface. And this is an example of what the dashboard looks like. In the top left quadrant, we have a risk adjuster observed over expected monthly rates of AKI. They could actually toggle back and forth between that and a P chart for statistical process control, sort of plotting over time if they prefer to use that. In the top right quadrant, this is where I used observed over expected rates and used benchmarks against their own VISN region, their VA region, and national rates of AKI, so they could see how their performance was compared to their overall sort of regional benchmarks. In the bottom left, this is not a very good example of a SBRT, but it's a risk-adjusted sequential probability ratio testing plot that I'll go over in more detail in a moment. In the bottom right quadrant, This is all just sort of fake data here, but it gives you an idea of what the patient registry would look like. So you'd have actual sort of patient names or MRNs that you can link there with key process and outcome measures that are being pulled up for their specific site. And we produced this for all of their cath lab patients and then for their CKD patient population as well. So the observed over expected site performance was using a national risk adjustment that we had published before this award. It ranked orders against their sort of benchmark sites, and the confidence intervals are related to their sites sort of sample size for that reporting time, et cetera. Excuse me. So the site level observed expected ratios over time, it uses the same risk adjustment for the over E methods, but basically reports this on a monthly basis and plots it on a monthly basis. They could also toggle back and forth between the over E monthly data, which is risk adjusted, to unadjusted or just crude data in statistical process control P charts. And then they also had access to the lower left quadrant was the risk adjusted sequential probability ratio testing, which provides a formal framework for encoding both in alpha and beta errors for analyzing and accumulating their data. And specifically, you can specify an odds ratio a priori so that you're using clinically relevant detection instead of just statistically relevant detection. And it accounts for patient case mix and variation through risk adjustment, as opposed to just using QSUM or another SBC method. So what we're looking for here is that if the SBRT line actually crosses the top threshold line, and essentially that upper control limit is the one that confirms an outlier signal, signals that they're at higher risk than would have been expected alone. And so SBRT methods are a little bit of like flipping a coin on its head. So instead of having a null hypothesis and an alternative hypothesis, you essentially have an alternative hypothesis, which is that there is a hypothesis that there is a difference, statistical difference. And by crossing that upper line, you're accepting the alternative hypothesis, not rejecting the null hypothesis. So you can make that spin around in your head a little bit, but you're accepting the alternative hypothesis, but that there is in fact a significant difference than would have been expected. So this is some examples that we train them on what they might see in terms of their SPRT plots, with the bottom plot showing one example where they're crossing that upper threshold line, indicating that there is something occurring in their system that is not due to chance alone, and they need to investigate it. And the study team was actually surveilling all of the SBRT plots for the ASR randomized sites on a monthly basis to work with the teams if they're being coached. And this is the patient case level views, where they had essentially this registry lookup where we had process and outcome measures, so that it was easy for the teams to identify these key measures, and they didn't have to go find that data themselves, but it was readily there. And then the blue highlights on the patients, they could actually just click on that and it'd go to their CART cath lab data to look up more details about those specific patients. These are some actual examples of the automated surveillance reports for one site. So this is for all patients. We have over E adjusted plots in the top left. On the top right, this is their benchmarking or over E, risk adjusted over E, compared to their VISN region and national benchmarks in terms of how they're performing. In this example, they're performing significantly better than the national average, and not significantly better, but performing better than their VISN in their region. And their SPRT essentially shows that their plot is actually declining and not inching up towards the sort of risk threshold, and the patient registry is blocked out. This is the same site, but looking at their CKD patients. So they could toggle between all patients and CKD specifically. For technical assistance, this was led by Rick Solomon, and this is where sites, whether they had a multidisciplinary team or not, had the same number of touch points as the Learning Collaborative, and they had one-on-one calls. The only thing is that they had the protocol, they could ask questions, but the trainer, Rick Solomon, could not actually hold their hand and coach them through the implementation of the practices. So it's essentially like having like assistants or technical assistants on implementing the protocol, but not being coached. The other major intervention was the virtual learning collaborators. So these were occurring on a monthly basis, just as TA was, for about 60 to 90 minutes. And this is where the teams, instead of having one-on-one time with a trainer, had a group of trainers and also were coming together as multiple institutions. So 5 cath lab teams were joining these sessions as one, learning from each other's and having a lot of peer interactions. This is the Learning Collaborative AKI Prevention Toolkit, where on the left, we have a clinical topic that we're walking them through AKI preventive strategies. And that was paired with quality improvement implementation components that was being led by Dr. Zubkov, who's now at UAB. So the VLC intervention was led by myself and Dr. Stabler. And this is essentially the schematic of sort of our action phase of where we were. So we had some baseline data, some pre-work. During the action phase, we had our educational sessions, coaching and mentoring, and email and phone follow-up, and Dr. Zubkov led them through some PDSA and quality improvement activities. And now we've moved on to our sustainability phase. So the learning collaboratives needed to attend these 75 and 90-minute calls. They'd have small trial tests of change each month that we led them through multiple PDSA cycles. They submitted updates of their implementation. They used SMART goals to identify some goals and aims that they wanted to work through within the focus of AKI prevention. They also reviewed data and data displays to describe their improvement activities. So we had one learning collaborative that didn't have the dashboard and one that did. And then they communicated with one another and with the training faculty. So the monthly measurement was focused on process and outcomes measures. And again, for those that had the dashboard, this was a lot easier for them. For those that didn't have the dashboard, they really struggled to try to collect this information, even from their local cath lab data. The quality improvement training, as I said, was led by Dr. Zubkov, and we encouraged them to develop multidisciplinary teams. So it's not just the cath lab team, but sort of branches out broader than that within their institution. We had them understand that the cath lab is not just working in isolation as a microsystem, but it's truly a mesosystem that's interacting with the same day unit, the cath lab holding area where a lot of the fluid boluses are being done, the cardiac critical care unit, and also the cardiac ICU. We train them on how to sort of develop effective teams, work them through some PDSA cycles on sort of their goals and objectives, and sort of had them work through sort of an action planning process. They developed SMART goals. These are some examples of the outcomes and process measures that some of the sites might have employed, looking at IV fluid volumes, reducing AKI rates, and also documentation of IV and oral fluid volumes so that they can improve on that to monitor, are patients getting adequately hydrated before the procedures. And that all sort of brings back to sort of looking at process measures and outcome measures, which again was much easier for the ASR dashboards that was developed to make that an easy tool for them to do. So moving on to the results, and I'll finish in a few minutes so I have time to discuss. So amongst the 76 VA cath labs that were eligible and invited to participate, 20 were randomized to the 4 interventions. The only dropout that we had was in the TA ASR that was reduced to 4 sites instead of 5. We actually were powered to only have 16 sites, but we over-enrolled at 20, so we'd have 1 additional site per cluster. But this event wasn't a non-compliance dropout. This was a site that after randomization was actually shut down as a cath lab in the VA system, so they just didn't have an opportunity to participate. So overall, across the 20 medical centers and the 4 clusters, we had 4,500 patients, including 1,300 patients with pre-existing CKD during this 18-month phase 1 period. And overall, the population characteristics across the study sites and the 4 interventions were pretty well balanced. And we had over 500 AKI events and 214 amongst the CKD population. In the left, we have crude AKI rates by all patients, and on the right, we have crude AKI rates by CKD patients. So we see that the VLC, so the Learning Collaborative with the dashboards, actually had the lowest rates of AKI in both all patients and the CKD patients. That translated into a statistically reduced rate of AKI at an odds ratio of 0.56 compared for the VLC and ASR dashboard group compared to technical assistance alone. We saw a similar trend in the CKD population, but not a statistically significant trend, which might be due to the fact that the CKD patients had already may have had protocols in place to prevent AKI, whereas the non-CKD patients, there were no existing protocols. And so we saw the most advantage there. But that was an interesting finding, and part of it might be a power issue as well, which we might find out more during our sustainability phase when we double our power. This looks at all of the primary comparisons, and in the bold top left, ASR versus VLC, you see they're highlighted in bold. And this was consistent at a 0.56 for whether we adjusted or didn't adjust for patient features, but we didn't find a comparable statistically significant finding for the CKD population. However, when we do further adjustment using site baseline rate of AKI, so did sites in the ASR and VLC group come in with better rates of AKI? So if we address that issue, they still have a lower rate of AKI at a confirmed odds ratio of 0.54. And also adjusting using the site baseline observed over expected rate, adjusting for that, also found the same exact finding. This is just plotting those primary and multiple interactions in this 2x2 factorial comparison. Looking at the top, we see all patients. At the bottom row, we see the CKD population. And then starting with the no baseline adjustment, the baseline AKI rate adjustment, and the observed over expected ratio adjustment on the far right. And then we also did some sensitivity analysis looking for AKI events up to 30 days in case patients were coming back for creatinine measures that were outside our 48 to 7 day window. And we found exact comparable results of the odds ratio of 0.60. That was also statistically significant, looking for AKI rates up to 30 days. And this would also capture if there are any new dialysis events that were occurring outside the hospitalization window. So I want to spend a little bit of time and focus on this fidelity table. So this looks at the site randomization arms, the technical assistants with the dashboards, learning collaboratives with the dashboards. So this looks at fidelity to implementing the interventions. And what we found was that the virtual learning collaboratives with the dashboards were the most successful at implementing almost all of the interventions. They also, in the red text, had a higher number of dashboard hits compared to the technical assistance arm as well. So 77 versus 106. So they utilized the dashboard more during that 18-month period of time than technical assistance with the dashboard. Some of our qualitative results, we found some barriers to implementing AKI preventive strategies. Some of these included sort of lack of time for hydration or pushing fluids for patients, lack of having a set protocol, provider hesitation to have a standardized protocol, and lack of buy-in from providers. And when we looked at reporting facilitators, their core areas including prioritization of patient care, increased awareness of AKI, strong communication amongst teams, vigilance of nurses, automated order sets, developing close relationships with the nurses and strong team culture, developing automated order sets. So again, mandating the order set process in the systems, training for the study, and learning from other centers, learning from their peers. So overall, like Improve AKI is a randomized implementation trial, and it demonstrates the combination of virtual learning collaborative with automated surveillance reporting significantly reduces AKI by about 40% and is suggestive of a reduction in the CKD population as well. I think we'll learn more during the sustainability phase. And so the combined training of the learning collaboratives, as well as having a dashboard and team-based coaching, is an effective, scalable intervention that can establish aggressive preventive protocols to prevent acute kidney injury. So now we're completing our sustainability phase and our cost analysis over the next few months. And then we'll be going on to do some preliminary findings, specifically looking for scalability measures, and our cost analysis will inform that, so that we can look to more broader national dissemination, and especially trying to disseminate and scale these findings outside of the VA, which I think will be the hardest part, especially how to port a VA-specific reporting dashboard outside of the VA in different variable electronic health records, and how to standardize that. And then I want to bring this back to sort of what does this mean for implications for UAB and sort of learning health systems work that you're engaging with right now. So be thinking about automated surveillance reporting dashboards, that they could be helpful tools for clinical care teams to automate near real-time reporting of process and outcome measures. And in thinking about developing those dashboards, think about leveraging existing resources within your health system and informatics teams to support ongoing and new improvement initiatives within the health system. And I would specifically recommend that, consider also developing institution learning collaborative models. So learning from our virtual learning collaborative model, and do that across institutions, so not just UAB, but to facilitate training for teams, to develop ASR dashboards integration, which I think is viable within some of the collaborations that you have, foster further peer collaboration to learn from one another and getting that peer feedback, to leverage existing partnerships like the CCTS, this new Deep South network that's been formed, and also PCORDNet and other, I think it's called like OneFlorida maybe, and other collaboratives that you have access to, where you have a single sort of informatics synergistic sort of neighborhood where you could feasibly develop dashboards for these improvement teams to support their additional healthcare improvement and patient safety objectives. So that's all I have. Hopefully that was 45 minutes and we have some time for discussion.
Right on cue. That was fantastic. A great overview of sort of where you started and sort of where you're landing right now. Any questions for Jeremiah? And if you have a question, feel free to jump in, because there are tons of you on the Zoom and I may not be able to see whose hand is up. So if you've got a question, feel free to jump in. Well, I have an initial question while people are sort of thinking about that. And actually, every question you had, you sort of ended up answering. But I'm curious about how you developed what goes into the toolkit. So what was the set of services that you were going to provide to the sites, and how did you come about deciding what that is?
Right. So we developed the dashboard trying to keep in mind specifically what process measures and what outcome measures would be important for teams that they could actually take action on. And also those measures that were, more challenging for teams to develop. So when you think about developing observed or expected sort of rates over time, whether it's a monthly basis or the top right quadrant, which is more for benchmarking against their region, their VISN, and their national benchmarks, that is very challenging for a frontline clinical care team, even maybe with an analyst to do. And so if you can centralize that through an informatics team and produce that in a dashboard, that saves them a lot of time and also gives them more valuable information about their risk-adjusted rates over time, as opposed to just relying on statistical process control methods that are, largely using just crude data and not risk adjusting for patient case mix. So that was one thing that we wanted to address and sort of make easy for a team. Also, for the benchmarking, the top right quadrant, we wanted to have some observed or expected risk-adjusted rates for their site and show them where they stood against their VISN, their region, their national benchmarks. And that was a true indicator. So we had some top performing teams that, started in a good place and even ended up in an even better place. But we had other teams that were statistically significantly higher than their vision, their region, and even their national benchmarks. And we saw them during the collaborative time moving their site-specific rates actually quite rapidly to the left side, to where they're a top performing site in their vision, their region, and against their benchmarks. So I think that benchmarking plot was really a driver to engage cath lab directors and teams to become an early adopter and top performer in their region and nationally as well. And the bottom left, the risk-adjusted sequential probability ratio testing, that was leveraged by Dr. Matheny in some device trials and observational studies. And we wanted to apply that, building off of our national risk model for AKI as a surveillance tool in hopes to give them sort of an early indication of going the wrong way, so to speak, or an early indication of multiple events stacking up in time. And I don't think we saw any site actually cross the upper threshold line, but we did see sites sort of approach that line, but not crossing it. But our hope was basically to provide as an early indication of risk in their system for AKI. So that might be a new interventionalist that has a different practice pattern than the team was using all along the way, and they're stacking up sequential AKI rates, and that will push their curve up higher. So we wanted that surveillance feedback. And then the patient registry, we wanted to get the crude data at the patient level or procedure level back to the teams in an easy fashion, so they could have their precise process measures on their volume fluid status of their patients, their contrast load, their safe dosing of contrast that was sort of calculated for them, so they can see if their contrast dose was exceeding their safe contrast dose limit. And then that could be an area for them to target for improvement, as well as their fluid protocols and AKI rates, et cetera. So we really try to go at it with sort of a process and outcomes approach in terms of what things did we want to have teams to have access to that would be actionable.
Okay, great. Other questions from anybody? Mike, you were looking like you were unmuting. I don't know. No? Okay. All right. So Jeremiah, thank you so much. This was wonderful. Much appreciated. Lots of things for us to think about and consider. So thank you so much for taking the time. Much appreciated that.
It's an honor and privilege. Thank you for listening, and I'm happy to answer any questions offline should you have them. Thank you.
Okay, great.
Bye.
All right, take care. Good.
Bye.